Good morning, everyone. So, how is everybody today? Good, good. Well, my tired and hot, I bet, for those of you who aren't from Florida. So, does anyone live in Florida? That's from here? Oh, a couple of you are used to the heat-ish, right? So, I was just talking to a family here and we were discussing how, it gets to 90, but it just feels like maybe 100 or something like that, right? So, is anyone a native Floridian? Those of you who are here? No? Well, guess what? I am born and raised here. So, well, my name is Amy Thomas. I'm a speech therapist, and just a little bit about myself. I've been practicing for about 17 years now, just over that, and I am a clinical instructor at the University of Central Florida. I have worked primarily with pediatric clients throughout my career, pretty much working with a variety of diagnoses and working with language disorders, varying diagnoses. I've worked with clients who have complex communication needs, who use augmentative communication devices, apraxia of speech, which we'll be discussing today, and then language disorders, speech sound disorders, and a variety of needs. So today we'll be talking about apraxia of speech, and I'll have a Q&A session at the end, but please, if you have questions as we go along, feel free to ask them. All right. So first, just a disclosure statement. I am receiving no financial or non-financial relationship to this particular presentation. And then just overall, some topics we'll be discussing today will be just in general, speech-language pathologist focus areas and childhood apraxia of speech, as well as the principles of motor learning and how that applies to treatment. And then also treatment approaches in general, and then finding an SLP. So I know that was a topic when I was speaking with Allison, and basically, what would be a good team? There were some questions asked, like how we could work together as SLPs, and then working with you to have a therapy approach that would work. And then additional supports that might be needed to help your children go through the process of therapy with communication disorders, and then, of course, apraxia of speech, and then the Q&A session. All right, so just a quick overview of speech-language pathology and what we do whenever we're working with clients. So receptive language, we focus on language understanding. So some examples of that would be following directions, answering WH questions, identifying objects. Those are just examples. And then expressive language, so that speech output. It doesn't have to be verbal speech, but it could be augmentative communication, labeling objects, grammar skills overall. And then we also work on speech articulation. That can be specific sounds individually. It can be augmentative communication, so expressing needs and wants, but then also childhood apraxia of speech. We also work on social skills, pragmatic skills, that communication interaction during your daily activities, how those particular interactions, how play skills develop all the way up through social skills in the environment, doing daily activities and becoming more independent. So when it comes to apraxia, there are two types of apraxia, and childhood apraxia of speech, it applies more to children, and then you might have heard of apraxia or acquired apraxia of speech. So the difference is, one is more referencing children, and that motor plan to produce speech especially on demand. So that's sequencing of speech production and how we can program motor movement to produce speech on demand to convey your message. It can be from the sound all the way up through phrasing and then sentence structure. And then acquired apraxia of speech is usually used when we're referring to adults. And again, it's that neurological component for planning the sequence of speech production with adults typically, and the acquired component means usually there's a neurological event that has happened. Usually it's something like a stroke or a traumatic brain injury. And there's two references on this slide. The childhood apraxia of speech is, that website is from Apraxia Kids, has a lot of great resources if you haven't looked on there for childhood apraxia of speech. But then the acquired apraxia of speech, the one that's referencing adults, is actually from the Speech Therapy National Organization, which is the American Speech and Hearing Association, which has actually a plethora of information related to just speech and language in general, but it does have information about childhood apraxia of speech as well. So characteristics of childhood apraxia of speech. So there can be inconsistent or distortions in specific vowel and consonant sounds, and that can change from moment to moment at various production levels, but especially on demand. So maybe whenever you hear your child playing or interacting just on their own, they might be able to produce a certain sound, but then when you ask them to repeat that sound, then they have difficulty producing it in the same way. So there's inconsistency in production. Then speech sound production is, like I said, usually worse whenever you're adding to that demand. Then there can be voicing errors. Have you heard of that before? Anyone? No? All right, so I'm gonna have you guys practice or give you guys an example of this one. So there are certain speech sounds that we produce in the same manner, and the only difference would be voicing. So if you're thinking about B and P, and you want to put your hand on your throat, and one particular example would be the B sound you're going to produce with voice, so you should feel some vibration here. So if you do B, B, you should feel a little bit of vibration. But if you produce the P sound, you shouldn't feel vibration. So, P, P. So can you feel the difference there? So sometimes whenever you're producing different words, like let's say you were trying to practice the word be, and you produce the word be, and you should feel the vibration, be, but then if you were trying to do P, then you might, just make sure you're thinking about the P sound, so P. You're going to feel vibration for the E, because E does have voice, but the P does not. So you might be practicing B, but then that voice drops, so it might come out as P. So maybe on repetition. So here we have that distorted or inconsistent type production happening. So if you want to do B 2 times, it could come out like B, P, even though you're trying to do B, B. So that's where we see some of that inconsistent production happening with apraxia of speech. And then there's varied speech rate. So it can be really fast one time, it can be slower on a different time, or there can be different stress on words. So maybe there's mommy one time or mommy a different time. Or it could be a phrase, if you're doing phrase level, where it could be I want or I want. So something that happens in that instance, it can come across as maybe being a fluency or stuttering disorder. And so there's some difference in what's perceived from a therapy standpoint. So when you're thinking about speech, or when we're looking at a client, we're trying to decipher apraxia versus fluency disorders versus individual speech sound disorders. There can be oral groping, where as a client is trying to produce certain speech sounds, they might be having difficulty putting their mouth in the position that needs to be made to produce a certain sound. So in the same instance of trying to do the B sound, maybe they're having trouble putting their lips together. So, buh. So they're trying to put the lips together, close them, and then produce the air. So that's something that we might see. And it can change from moment to moment. There can be insertion of sounds. So sometimes we see the sound so cuppa. And so there's an exaggeration or an extra sound produced at the end of a word. It doesn't happen all the time, and that's that varied production. And then sometimes we see speech deteriorate or change as the length of utterance or the longer the word. And so that's where that varied production occurs. And then there can be a difficulty initiating speech. Yes, did you have a question? Sorry, okay. So it can be perceived in that instance as maybe somebody thinks that your child isn't understanding a question or isn't paying attention, when that's not the case. They're just having trouble responding verbally. So that's something that we also want to look at when we're looking at apraxia of speech. So one thing we also want to look at when we're working on therapy is the principle of motor learning. And that is basically, how do we put together this approach of sequencing movement to be able to produce certain speech sounds and then work that all the way up to fluent speech. So from the brain to speech production, it's patterning and programming speech movement or any movement to be able to produce speech. So an analogy might be riding a bike. So remember how you have to, position the bike. You have to get on the bike. You have to be able to put the pedals or the handlebars in one direction and put your feet on the pedals and be able to move them in the right direction, be able to balance and maintain all of those patterns to be able to do a smooth bike ride. So thinking about that, there are a bunch of motor movements that need to occur to be able to smoothly and effectively ride a bike. Same kind of principle applies to speech production. You need all of those fluid movements to be able to produce certain speech sounds all the way up to conversation. Has anyone, oh my gosh, I didn't turn the slide. All right, so has anyone seen this picture before? Or a version of? This is a homunculus. So basically what this is a picture of the brain, and it's a representation. It's in your frontal lobe, and if you were to think of a watermelon and a slice of a watermelon, the triangle, and if you take that triangle out, think of the green, the rind of the watermelon, and then your pink part here, and this area on the side, where all of the body parts are, that's a representation of all of the area of the brain and how much, basically, message that the brain has to send to be able to make these different parts of our body move in a functional and effective, smooth way. So all of the areas that you see that are bigger, they require more motor planning and more information from the brain to be able to move very detailed, very fine, and clear to be able to do whatever function they need. So if you look at the first half of the brain at the top, you can see that almost half of the body is from toes to hands, takes up half of the brain. But then if you look at the bottom half, what is that? That's the face. It includes the lips, the tongue, the jaw. All of that area requires a lot of innervation and a lot of focused movement in order to be able to do specific, not only movement for speech, but also for eating and drinking. So you can see why just one little bit of movement that may be just a little bit off in that motor movement sequencing can really affect speech sound production. So I just wanted to show you all that and why just something that can be slightly off can affect speech sound production. And if you look up that word, maybe in Google, you'll see all kinds of forms of the homunculus. This one is just a smaller representation, but it has a bigger view. All right. So whenever I was preparing to speak to you all today, I was looking at different therapy approaches and then how they applied to SATB2 associated syndrome. And I looked on the website, your website, and I noticed your review of there was a study that had been done related to speech and language therapy with SATB2 associated syndrome. And I looked at the background information and how rare, I know this is all what you know, but the 500 cases worldwide. And then I also looked at what particular therapies that families knew or reported had been used with their children during therapy, treatment therapy with speech-language pathologists. You had reported that a number of therapies had been used, but in particular, prompt therapy, Kaufman card, or the Kaufman speech praxis therapy approach, the dynamic, temporal, and tactile cueing approach, and speech easy apraxia approach. And those were just some of the ones you had used. I was just going to talk about three, at least the top three that you had mentioned in that study. That seemed to be the most ones that had been talked about, and so those are the ones that had been most mentioned by families who had known what was used in their sessions. So prompt therapy was an approach that was developed by Deborah Hayden, and it's prompts for restructuring oral musculature phonetic targets. So it's a motor-based approach, but it also looks at kind of this whole person, whole body approach. It's not just about oral motor placement for particular speech sounds. It's also looking at a linguistic, cognitive component. It's looking at a sensory component. So it's a very well-known approach for therapy, but it's looking at all of those components, like I said, this whole person approach to be able to achieve speech sound production and then develop into clear speech at a whole level for communication. And then the Kaufman speech praxis protocol, that was developed by Nancy Kaufman. Again, it's a motor-based approach, but it's looking at, what's functional for a family. Nancy Kaufman is big on giving a family or a client something that can be used in the moment in context to help a client. So, for example, if your child has difficulty relaying what they might want to eat, instead of crying, what she's going to do is maybe help give them an approximation for, let's say, cookie. So maybe she's going to work on k, and then in context, you'll know that if you're sitting in the kitchen, that k could mean cookie, so you have to use that environment. to know that cookie in that room is k versus just crying, and then you have to go through that whole list of what k could, or what crying could be. So could it be cookie? Could it be juice? Could it be their favorite toy? Could it be the movie that they like to watch? So it just helps to reduce the frustration for everyone involved. So that is something that Nancy Kaufman is big on using. And then another therapy approach would be Dr. Edith Strand's approach, the dynamic, tactile, and temporal cueing technique. So her approach, again, it's working on what's functional for the client, but it's also a motor-based approach. She is using a lot of tactile input, but she also works on this approach where there's what works best for the client. So she might be having some imitation in the moment. So if I'm saying the word ball, then I'm going to work with the client to say ball, but at the same exact time. So we're saying it together, and then also I might mimic it with my mouth, but without voice, while the client is saying ball on their own with voice, and then we back off that cueing. So that's just another way of doing a therapy approach. So what do these three have in common? Number one, this motor-based sequencing approach to speech production. They use a variety of cueing techniques, oftentimes with some form of tactile cues. They focus on a hierarchy of production, starting at a very base level and then building on that success to be able to produce a grander amount of speech production. And then all times, they're all working on some form of a functional production of speech or an approximation, something to help to reduce that frustration and communication all along. All right, so one thing that study from November 2021 did say was, let's see, perhaps the most interesting was the number of parents and caregivers who were unaware of the type of therapy used by their speech therapist. Now, as a therapist, that was heartbreaking because, it just was frustrating to see from our standpoint that you all didn't know and what was going on in a therapy session. Because for us, you are the people that are doing the carryover. For us, we are somebody that is working with your child for 50 minutes, 30 minutes, however long your session is, 1 to 3 times, whatever insurance or private pay allows. And I know that is a financial expense that is one of many therapies that you potentially are going to. So for us, you are the great carryover and the consistent person that is doing therapy. So if you don't know what we're doing, that's not okay. You have every right to know what's going on in our therapy session. And for us, we should be telling you. And that's not to be disrespectful to any other therapist in the profession. That's just, what we should be doing to help you understand and to help with carryover. So, for us, here's what I can tell you. To find a therapist that you feel comfortable with, both you and your child, if they're an adult too, all of you have a voice. Each of you have a voice in the therapy approach. Please ask questions. If your therapist doesn't have an answer, then maybe they can say, and this might happen, they can say, oh, let me get back to you on that. But that's okay. I've said that before, let me get back to you with some answer. But if they don't give you an answer, it's okay to push for an answer. Ask about a specific therapy approach. Ask them, why are you doing this instead of this? I read about this approach. Can we try it? And then, maybe be willing to talk about and break down why a therapist is doing one approach with your child versus another. So you guys can kind of come to an agreement and try one versus the other. And again, it's okay to tell us your concerns. If you have something or a view on why we're doing a certain approach, please tell us, and then we can work together. And then another important thing is tell us how carryover is going at home. If a homework assignment, so to speak, is not working for you, please let us know so that we can work together to find something that does work. And then one of the most important things, please request a copy of your therapist's goals, because if you don't know what we're working on, then that's not okay either. You might have reports that you have to give to another professional that you're working with, and that helps with this whole team approach for multiple professionals to be on the same page. So please ask for those goals, and then if you don't understand what it is, let us know, because we should be telling you what that is. And then some things that we need from you to help that team approach work effectively would be just like you guys are asking for reports, we need to see whatever reports that you have from physicians, from any sort of team player that can be involved in that therapy interaction. So it may not seem like it, but a report from a neurologist can give us a lot of information. Things like medication can help us with coming up with therapy plans, because certain medications tell us, oh, this might reduce some muscle strength, or certain times of day when certain things might be best to work on certain activities because of potential sedation that might occur with certain medications. So it kind of gives us an idea of what's going on with certain events that are happening with your child. Tell us your concerns, just like before. And tell your SLP if there are other professionals so that we can collaborate and all be on the same page. So school SLPs, private SLPs, whatever it is, OTs, physical therapists, whoever it may be. And tell us what motivates your child, so we can use that to our advantage to kind of motivate and engage with your child and produce therapy activities that would be fun. And on a side note, please tell us what they don't like. Now, if they don't like coming to speech, we're going to do our best to make that a fun experience. But if there's something specific, a certain video character or something, we certainly don't want to pull out, Blue's Clues, or I'm trying to think of somebody a CoComelon. That's one right now that seems to be highly favored. So if they don't like CoComelon, we don't want to bring that out and cause a refusal situation. And then what are your expectations from therapy? Let us know, because then we can talk about how that might look at long term. And also know that there's a team approach, and we want to work with you as much as you want to work with us. So please just let us know. And then some other kind of approaches that we might use or we might recommend are some augmentative communication and supports. So I know we're going to have some other speakers later that will be talking about different augmentative devices. I already see that some families have been using some AAC devices, so that's something we can talk about. The oral motor placement exercises or oral placement, that could be part of that sensory component to help your child learn where certain parts of your mouth need to go to produce certain speech sounds. And a mirror, certain tools, and I have some of those things here today if you're interested in seeing some, if you're not familiar with them. I also have some of the Nancy Kaufman cards, if you want to see any of those, if you haven't seen them before. And it can show you that speech progression that I was talking about, how you might do, this is a consonant vowel, or a vowel consonant card, the word is up. But if your child isn't able to say up, you could start with a. So in context, if you saw this picture, then you could target a, and then maybe up, and then put those two together, up. So you're building that progression of a word by producing single sounds at a time. And then some other things that we might need to work on as we're working on speech, some behavioral kind of approaches. So maybe we have a schedule board, a visual representation of, oh, we're going to say this word 2 times. So we have picture symbols, or a first then board that says, okay, we're going to work on our speech sounds, and then we're going to take a break and watch a video. So something like that helps structure our session for different production of speech and things to make it fun and give structure. And then, of course, we're going to address the sensory needs, because sometimes we can't give the cues that would be beneficial if there is an aversion to touch on face and anything inside the mouth that could be beneficial for speech production. And that is it from me. Does anyone have any questions? Hi.
So my son is 21. We've been through a lot of speech since 18 months. And what I believe is it's the oral motor, definitely, but also just bringing, I don't know what it's called. I feel like he can't project air enough up and get that airflow going to produce a sound. Now, when he's excited, he can do it, but on demand, he can't. I've kind of talked to a few speech therapists about it, but I never really got, a good explanation of what that process is, and is there anything, that you can do about it?
Yeah, good question. So, as speech therapists, we pretty much learn anatomy from the diaphragm up. And so it's definitely a component with speech production. And yes, there can be an apraxic component to that breath and support and coordinating it all. Sometimes it can be related to just an overall motoric, apraxic, whole body type approach. May I ask if there is any other, besides a speech apraxia diagnosis with your son? Okay, so,
Typically, I don't take anything else.
like,
Typical TAP symptom.
okay, it's the reason why is that like a limb apraxia, or if there was any other diagnosis like that.
Oh, sorry. No, there isn't any.
Okay, so sometimes, it can be doing things like, some motor movement. So like with that homunculus of getting the whole motor movement going, and then working on the speech sounds, or, and getting that breath movement going as well. So if you're saying it can happen, spontaneously, but then just working on that approach with getting the motor strip going and getting some of that breath support going in conjunction, and that can maybe help with the speech
You mean like the
production.
gross motor stuff going?
Yes.
And then, okay. Thank
Yeah.
you.
Yeah, is that something you've tried before?
No, I haven't. That's
Yeah.
a great idea.
So sometimes, this may be harder because he's taller. Is that your son
Yeah.
next to you?
Justin.
Yes. So, and it might be something to work with PT, but some things that I've done in the past is use a therapy ball, and I've worked with OT and PT with this, so that's their area, so you want to work with them. But like a therapy ball that would kind of give pressure on the abdomen, and then kind of rolling back and forth, so you get some
Uh-huh.
movement with the breath support.
Okay.
That's one thing that I've used in therapy. But again,
Uh-huh.
having that reference from an OT or PT, since that's their scope of practice. So,
Are there any, like papers out on that kind of what you're doing there with the rolling with the ball? Any other?
you know what,
motor-
I could get something from, I'll talk to our PTs. We work closely with them. They're in our same college at UCF. So I'll talk with them and see if I can get a paper on that. This was from a PT and an OT that I used to work with at a clinic. So let me get
Okay.
that for you.
Thank you.
Yeah.
Right. I got a couple from the virtual. So one question is, what steps would you recommend for resolving an awkward relationship with an SLP? My daughter's SLP, who does her AAC therapy, gets very defensive whenever I advocate for my daughter and takes any questions/feedback as a personal attack to the point where she's made multiple nasty comments. She's the only SLP at my daughter's clinic with AAC experience, but I'm not sure how to advocate for her. My daughter, or advocate for my daughter, or even inquire about my daughter's speech sessions without offending her.
That's a tough call. Yeah. I think that is a really tough call. So for me, if I've ever had a situation where a family is uncomfortable, then, we just keep talking about it. But I might see if there's another therapist is there a supervisor above her? I know that might be kind of scary when it comes to potential fear of how that interaction would go with her child. I might talk to another therapist, or can she sit in with the therapy sessions?
Great suggestions. One other question, which might be something that we need to all as families join in on the chat, but was asking, have any families seen more success with their SAS kids in any specific speech therapy approach? We've tried prompt for the last 3 years with minimal gains.
Yeah. Has anyone seen one particular approach? I know as a therapist, I can't say that one works better than the other. I mean, advocating for one over the other, is not ethically something that I can do. As an individual therapist, what I can say is I try to look at what works best for a specific client.
We had some experience about dealing with the behavioral aspect first, because we were taking to a speech therapist and he was not complying to even participate at all, right? So that was the first big hurdle on applying on behavioral therapy. So one of the approach we had was to implement as much as possible the AAC during the ABA therapy as a tool, not as a target. So my question to you is, usually the speech therapy is not in a vacuum, right? You have a whole behavioral, PTOT all together. So even using the device, the coordination, the understanding, the cognitive, the behavior, then you can start using the tool, which is the AAC. So yeah, any recommendation on how to incorporate the AAC device training when you have such hurdles to go through on behavioral and everything else?
Yeah, so, I think just continuing to use AAC, but maybe looking at, it's hard to say, not seeing what kind of approach your therapist is using for modeling AAC. Sometimes it just takes a lot of repetition with that guided access. The modeling, I'm losing my term here, but the AAC modeling, and how often, how frequent you're using it. Sometimes it's a matter of having a separate, not a device, because that obviously gets expensive. So you have the two. So just a lot of repetition of, modeling, and maybe in high interest kind of situations outside of your therapy session, you're doing that? Yeah. How about any referral to occupational therapy for a sensory kind of approach? Yeah, sometimes that can be a different avenue versus ABA or in conjunction with ABA. That might be another area to see about. I've seen both approaches be helpful to families, but I can't say one over the other, you know. That might be something else too, because it could be a sensory-based concern versus, that could be causing the behavior. you know,
So I don't have a question, but I just had a comment because Lindsay's been through the whole school system. And one of the things we did that made our speech therapist happy was we advocated for Lindsay to have not only speech direct service time in her IEP, but for speech sessions where the therapist would have time to program, meet with the teacher, just do planning. So she ended up with 15 speech sessions in her IEP, but they were not all direct service, because someone who is preparing to help somebody with an augmentative device needs a lot more planning time than someone who is just doing articulation or something like that. So she was very appreciative. And we had someone from outside the district help us request that, so it wasn't coming from her. So I don't know if that's something that people would put in their IEP.
Yeah, and sometimes it can be a matter too of whatever device it is, that a local device rep can come in and help support the therapist, at least initially, and help with programming and setting up. So that might be something that, that particular parent can work with that school therapist and see if that might help as well. So, yes, ma'am.
We're struggling right now trying to find the balance in Sylvia's allotted speech therapy time in school between focusing on use of AAC device versus actually working with apraxia of speech. She is verbal, but we're seeing a lot of regression. And so do you have any advice on that? Because it seems like in a lot of our kids, they can focus on one thing at a time. So the more time they're spending on using the talker with her and navigating it, which I think she's very proficient at, it seems she has stepped back from actually using her voice and continuing to learn to talk. So do you have any advice on, for any of us, what that balance should look like within 120 minutes of speech in a week? How do you balance that?
Right, and, sometimes that is, yes, I definitely understand your frustration. Sometimes it's difficult with not knowing what the school parameters are as far as how they can break up a session or what kind of cues they can give. I know here in Florida, tactile cues are considered invasive, so that wouldn't be something that they would be able to do. But in private therapy, we could. So as far as the speech production component, you could ask your therapist how they're targeting that speech production in conjunction with the device. So are they having your daughter produce the speech at the same time as the device? Or is it completely separated? Is it just AAC, or are they having her produce it at the same time?
They've shifted to purely AAC this year for whatever reason.
Yeah. So, that might be, I'm not sure, but, just having that conversation with that therapist of can they combine it? And sometimes with the IEP situation, it's solely based on your county or your school system as to how they classify it. Is speech verbal or is speech AAC? How do they classify it? Here we have some different parameters. If you're working on speech versus language, you can qualify for one or the other, or you can qualify for both. So it really depends on the school district. So, it would be wonderful if they could work on both at the same time so that it could be targeted. And that feedback of the AAC device plus the motor plan of finding the items gets the motor, motor going. And so that can be paired to produce speech.
Thank you.
Yeah. Anyone else? Well, my information is up there with my email address, amy.thomas@ucf.edu. If you have any other questions, please feel free to email me, and I'll be happy to answer anything that I can. And thank you so much for letting me speak today. It's been a pleasure. Just a quick reminder, everyone deserves a voice. Just leave that here. Okay.
Thank you, Amy, again for such a wonderful presentation. So I hope everybody gained some important knowledge. So just a couple of quick reminders. At 10 o'clock, we do have 2 sessions running. And here will be AAC 101 from Carolyn Buchanan with the University of Central Florida. We also have a table set up now from FAST, the Florida Alliance for Assistant Services and Technology here in the very back corner. Please go by and visit them. They've got a lot of samples, a lot of devices back there, a lot of really fun stuff. So check them out. In the Siesta Ballroom at 10 o'clock, there is the Adult Living Options led by Stephanie and Todd Watkins. Followed by 11 o'clock, I just want to reiterate that we will have a session here moving on with AAC implementation. We will also be doing roundtables. So there's some updates from the printed agenda. We will have the Adult Parent Roundtable, New to Diagnosis Roundtable, along with the Behavior Roundtable, which will be in the lunchroom over there, and a continuation of the Dad Support Group, which will be there. So adult parents, new to diagnosis, and Dad Support Group will be in the Siesta Ballroom, Behavior Roundtable at 11 in the lunchroom. So enjoy a little bit of a break, and we'll see you back at 10.